afternoon, everyone. My name is Christina Van Sickle, and I'm the Director of Professional Practice at the college. Thank you for joining us for this educational session, Practical Tools for Supporting Family Caregivers of Older Adults, presented by Dr. Adriana Schnall. Before I introduce Adriana, I'll go over a few housekeeping items. The session has live captions. To turn on the captions, click the Show Captions button below the video player. You can choose to see the live captions in either English or French. If you need tech support, please use the support chat at the bottom left-hand corner of your screen. Click on the icon and you will be connected with our live support. There will be an opportunity to ask questions at the end of the session. You can submit your questions through the chat feature on the right-hand side of the session page on the virtual portal. Now let's begin the educational session. I'm very pleased to introduce you to Dr. Adriana Schnall. Adriana is the Program Director of the Kaczynski Center for Innovations in Family Caregiving at Baycrest in Toronto. Adriana has 30 years of clinical experience working with older adults and their families, including outpatient community services, long-term care, and inpatient services. She has an academic appointment and the rank of Assistant Professor at the University of Toronto and teaches at the Factor Inwantosh Faculty of Social Work and at the Institute for the Life Course in Aging. Please join me in welcoming Dr. Adriana Schnall.
Thank you so much for Christina for that introduction, and importantly for letting me be here today, sharing with you some of the knowledge that I've gathered over the years working with families, with older adults, the research I've done in this area. And anybody that knows me like Adriana, the one that's into caregivers. It's like this little banner I carry. And so I'm so thrilled that there's enough interest that we're talking about this today. I wish you were here in person, I have to say, because it's easier for me to sense the crowd and see what you're thinking and feeling. But I'll do my best to transmit things that I think are important to know. And then at the question period, please ask all the questions that you have as they come up. So I just want to give you a brief overview today about Aging 101, I call it, for those of you that this is not your area of practice, so that you know some basic information. I want to talk about caregivers of older adults, and I want to talk about the kinds of supports that older adults need. Then I'll go into some ethical and legal implications, and then I'll leave you with resources. So, did you know that right now in Canada, about over 19% of the population is made up of people over 65? This has never happened before, that we actually only have 15.5% of kids under the age of 15. And this trend is going to increase by 2030, which is not that far away. It's really only 6 years from now. There'll be 25% of the population will be over 65. And I always say this, that this is crucial for all of us social workers and social service workers to understand that this is where a lot of the work is going to happen, because whether you work with older adults or children and their grandparents, no matter what group you support, you can't escape working with this population. And the other thing is, I was shopping, and I'm 61. And so, Seniors Day, Tuesday, or whatever it is. So I always go to them, like, so how old do you have to be here to get the discount? And some places it's 50, some it's 55, some it's 60, some it's 65. And when you look at that pretty much anybody over 50 or 55 to 120, whatever, belongs to one group, which is older adults. Think of the diversity. In no other age group do we have this. I mean, when you talk about a toddler, it's 2 and 3. When you talk about an adolescent, you think 13 to 19. A young adult, 19 to 28. But here we have a huge group of people. And so generally we talk about 65 to 74, we talk about the young old. 75 to 85 is generally the middle old. And over 85, we talk about the old, but I have to say that lately it feels more like until people are into their 90s. I don't now consider 85 old. But as I just said before, there's a lot of diversity within caregivers. And so we can't just talk about chronological age either. There's a lot of impacts, socioeconomic status, gender, cultural barriers, poverty, that really impact how people age. So people that live on the streets, age 50 years old, they're equivalent to an 85-year-old sometimes in terms of health outcomes. And you have older adults that are starting new families. You can have a 60-year-old father of a newborn child and starting a new family. You have a 60-year-old person with a younger onset dementia as well that lives in long-term care. So it's really important to think, we can't generalize when we talk about older adults. Some things that are important also to understand that as we age, there's a decreased ability to respond to stress. Not just our body, but mentally as well. So in our youth, think of people that live with trauma, that were able to manage, have a successful family, career, muddle through everything quite well. And at a certain age, you can't keep all the balls up in the air anymore. And so this happens to most of us as we age. Or think of those people that get injured. When you're younger, you fracture a bone. Within like 4 weeks, 3 weeks, you're running around. When you're older, you pull a muscle, your back. It's months sometimes until you recover. The other thing that's really important to understand is that genetics only explains 35% of the lifespan variance. We used to think, well, I'm going to live for a long time. My parents lived for a long time. This is no longer true. We now know that environmental factors, and those are good and not so good environmental factors, account for over 65% of the variance. And people don't age at the same rate. The environment, behavior, health are all things that affect our bodies and the way we go through life. And actually, we used to think, people are living longer and longer overall, but not necessarily so anymore. We have two divergent groups. Some people are going to live longer than before, but some people are going to age quicker than they ever did before. And for any of you that are interested in learning more about adult development and older age, the Harvard study of adult development is the longest study. It started in the 30s, I think 1938, and it continues. They have a second generation, a third generation. And at the end of the day, the factors that they find that make the biggest difference to healthy aging are avoiding cigarettes, good coping skills, and an attitude kind of making lemonade out of lemons, keeping a healthy weight, exercising regularly, and by that is not, you don't have to go running every day, but being active, moving your body, and maintaining strong social relationships is key, and pursuing an education. Some of these things people can do something about, but this is something as social workers and social service workers, you can help clients perhaps make some sort of an impact into not all of these areas all at once, but at least a few. And newer learnings now is, and I don't know how many have heard about epigenetics. And epigenetics is a newer branch of studying genetics and how behaviors in our environment can actually cause changes that affect the way that genes work. And so this idea that because you had a particular gene and things were set in stone is no longer accurate. And so epigenetic changes are reversible, but they don't change the DNA sequence, but they can change how the body understands the DNA. And this is good and bad. So for those people that experience trauma, and we know that those people, aging and life course trajectory and probability of developing illnesses is increased, that's not a good thing. But epigenetics also works for things like if you can exercise, if you can avoid cigarettes, if you can follow a particular diet, low stress, and all of these things. It has the 60%, 65% that is environment could be changed. Even we know for dementia prevention, up to 40% of dementia can be prevented with lifestyle changes. And for us social workers, it's not just the clinical piece, but also advocating at a bigger systemic to government and seeing what we value as a country, because without these changes, we have this divergent, as I said, some people, older people, getting older faster, and some, the lucky ones, get to live longer. And the other thing is I want to talk about aging is not pathology, but there are changes that happen as we age. And these changes do not necessarily portend poor health. So, for example, I need reading glasses now. I also need glasses for distance. I need different glasses for the computer. These are changes that, if you know anybody pretty much over 45, 50, people need at least reading glasses. This does not mean that I have poor health, but these are changes that happen. Hearing is another one. And this is just as an aside, but hearing is the most important sensory loss that we have that can predict dementia later on. So everybody, you should be telling your clients to make sure they get their hearing checked and that they can get hearing aids, which then they're so expensive. So this is a whole other subject, but it's a good way to prevent dementia. The other piece about getting older is most older adults, so I don't want to give anybody an impression that older adults are frail and sick. That's not the majority of older adults. But 85 and over, and this group is mostly primarily women. Women live longer. They have the highest and most severe rates of disability. And so the number of older adults with disabilities is expected to rise. And this is just, we said in 2030, 25% of the population will be over 65. So it's not that there's a higher incidence, meaning newer cases, but just because we have more people, there'll be a higher prevalence of some of these things. And the other things, disability rates for Indigenous groups, 55 and over, are much higher than for the general population. And this is important to note. The other things, disabilities for older adults come in different ways. Some are from birth. And just so that you know, people that have Down syndrome, over 75% of them go to develop Alzheimer's disease. There's the disabilities resulting from accidents and trauma. And then disabilities as a result of aging. Alzheimer's disease is not a disability, it's an illness, but now we're starting to question what is really Alzheimer's disease. And what's different about older adults is that most older adults have more than one disability. So vision, hearing, they may also have trauma, and which leads me to what we call geriatric syndromes. I'm giving too much information and I'm so sorry, but I just feel compelled to I want you to understand a little bit about older adults because it has a lot of impact into the work that we do. In younger groups, when we have a syndrome like Down syndrome, we generally attribute it to one cause. But as people get older, geriatric syndromes have multifactorial health conditions. So that's vision, incontinence, hearing, risk of falls, frailty. Okay, so that was my talk on Aging 101, the basics, what I think are the basics. And I want to move now to talking about family caregivers. And Rosalind Carter has this line that you may have heard, but it is so true, that there are only 4 kinds of people in the world. Those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So basically, we cannot be in this earth and escape this experience. I also want to talk about language. Caregiver, first of all, when we talk about caregivers, we generally talk about looking after somebody in a non-paid situation, which I don't like saying that because in other countries like the UK, caregivers, family caregivers get paid to look after their families because there's an understanding that this is work. Lots of families have to quit their jobs. It's mostly women doing this kind of work with lower paying jobs. They quit their jobs and then their pensions, financially, they really suffer. So I don't like saying non-paid work. I don't like saying informal caregiving because there's nothing informal about this kind of work. But it's not when I, as a parent, and I'm looking after my children, I'm not really a caregiver to my children. I'm a parent to my children. When we talk about caregiver, we talk about when we're dealing with a condition, an illness, end of life. The other thing I want to talk about is when I say family caregiver is because I don't know a better word because I don't like informal caregiver, but I also mean family of choice. It's whoever you feel close to. I also don't like the word caregiver, even though I use it, because it means it's unirelation. It goes to, I give the care to somebody else, and that's it. And we all know that in relationships, it works both ways. So it's not a caregiver. And so some people prefer to call it carer in the UK, Australia. I have a problem with the word, mostly because nobody knows what you're talking about. If you're saying, oh, the carer, people look at you like the who. And we use language to communicate. And a lot of people like the word care partner in recognition that we partner in this care. I just find it a little bit too businesslike. So I've been told, I use the word caregiver because for the most part, people know what I'm talking about. The other thing I learned lately, I was at a conference, a caregiving conference, and there was a man, Bruno Grant, he's Cree, and he talked about care gifting. And I loved, it really resonated with me because what he said, culturally for him, it's an honor to look after somebody else. And so that really, it's a gift we're doing for somebody else. And he was talking about his kids who live with autism. And then, of course, I kept thinking, well, maybe it's different when it's your kids because you love your kids different than perhaps your parents. But he was really, this is the language he uses. And so I'm sharing this with you because it's something really important to think about. I think that there's different ways of looking at this caregiving. That even though it's a burden for most people, sometimes the language we use and reframing and the beliefs that we come from, that we grow up with, can make the experience feel very differently. And lastly, the term loved one. A lot of people that we look after are our loved ones. We truly love them. But a lot of people are not our loved ones. I mean, we work with daughters who have been abused by their father, and yet they're looking after them. and they're doing it out of filial duty, guilt, expectations, whatever that may be, they don't particularly love that person. And if, as professionals, we tell people your loved one, we're really passing judgment on how how that relationship is. And yet you'll hear it everywhere, your loved one, your loved one. As social workers and social service workers, it's really important to use more neutral language. So I would just say your mother, your father, your sister, your brother, your neighbor, whoever that person is. And then people don't feel judged, and people may open up to you and tell you, you know what? It's really hard for me to be a caregiver to my father. I really hate him. And now that he has dementia, this is the icing on the cake. But I still feel compelled to do this. So why do we care about family caregivers? First of all, there's the financial piece. Did you know that family caregivers provide 80% of all the care to older adults in the community? That's in Canada. And 30% of care to older adults in institutions. And we saw what happened during COVID. Families weren't allowed to visit. The system, long-term care system collapsed. Caregivers who look after older adults save Canada's healthcare system between $24 to $31 billion annually. And overall, they provide $26 to $72 billion in unpaid work per year. And just so that you know, the latest stats, it's not just older adults, but caregivers, they save the Canadian government between $97 and $113 billion. Imagine if caregivers went on strike, what would happen to our healthcare system. But most importantly, it's not about all the financial piece that is really good for the government, but there's better outcomes for patients and families when we support them. So some of the variables that shape the nature of caregiving. One is the intensity of the care provided. So it's not the same if you live with the person you care for. So if you think of an 85-year-old woman living with her husband and providing care 24/7, and her being frail herself perhaps, and doing it all the time, is very different than the son from California who calls on Sundays and sends money. And I'm not saying one is a better form of caregiving or not. There's no better or worse. They all just are. But the impact is different. And just so that you know, caregiving is stressful, but it's not just stressful because of the physical and emotional tasks. It is stressful because worrying about somebody that of itself has repercussions around health outcomes. So even the son from California that calls once a week and is perpetually worried about, oh my God, I don't know if my mom's going to fall. I'm not there. I can't be there. There's nobody there. That worry piece alone is crucial to understand and support people. Also, we know the longer people look after somebody, the higher the caregiver burden. And so people looking after somebody with a dementia that could live for 20 years is very different than somebody being the caregiver to somebody with cancer who has terminal cancer and passes on within the year. The relationship also matters. So the closer the relationship, the more stressful it is. But the better the relationship, when I say closer, is wife, partner, as opposed to daughter, mother, as opposed to son, mother, or neighbor to the person. But the quality, so those that have really good relationships, have a good history, tend to fare better. Those that have more of an ambivalent relationship tend to do more poorly. So it's important for you to ask the kinds of questions about the type of relationship. If it's a long history of conflict, you can predict that relationship, caregiving relationship, is going to be more complex. Also, diversity of families, culture, gender plays a role. I have a colleague who is from India, and he's the oldest son, and he's known from the get-go that it was his role and his wife to look after his mother when she got ill. That's expected of him. And actually it was his wife's role, the daughter-in-law. She had to quit her job to look after her mother-in-law. That was just what was. Also, timing of entry into caregivers. So if you think about dementia, it's different if you become a caregiver when you're 70 than if you develop a younger onset dementia, which is before the age of 65 and you're 50 years old. That tends to be a more stressful situation because you still have perhaps children in the home, financial commitments. You may still be in the workforce and now expected to look after somebody else. And also the settings. It's a myth that when somebody places their relative into long-term care or institutional care, that the stress is diminished. It's just different stress. Now you have to trust the institution. Now you feel guilt that you didn't feel before. If the person falls within the first few weeks of being admitted, you think it's all your fault. So it's just different kinds of stress. And then the intersectionality of roles has an impact, socioeconomic status and gender. We know that in Canada, the statistics are that 52% of women are caregivers to 48% men. But what it doesn't say is the bulk of the work is still done by women. So the way Stats Canada makes these statistics is they ask, do you provide care to an older adult? And then they give you examples to drive them to appointments, do groceries for them, do their banking. But they don't count whether you just drive to an appointment once a month versus live with the person and provide all the care. So the lion's share is still done by women. Some effects of caregiving. One of them is burnout. And a lot of the symptoms are really symptoms of depression. There's a high correlation between depression, and especially for those people looking after people living with dementia. For men, it tends to be more metabolic illness. And for women, more anxiety and depression. There's social isolation, huge financial repercussions for people, family conflict. And did you know that dementia caregivers are at 600% increased risk of developing dementia themselves? So that's not to be taken lightly. So a lot of people ask me, what assessment tools should I be using to assess family caregivers? And unless you're doing research, my answer is just ask people, how are you doing? Or come up with a question on a scale, in the last 2 weeks, on a scale from 0 to 10. How have your caregiving duties affected you? Or just ask. You do not need some tool that gives you a score to know if a family caregiver's suffering. The problem is if you're going to ask, be prepared to do something, because there's nothing worse than asking somebody how they're doing and then doing nothing about it. So even if we do nothing else, 3 things we can all do to support family caregivers is to identify to them that they're in this role. Most families do not know that they're in a role of caregiver. They'll tell you, I'm a daughter, of course I'm doing this. This is what daughters do for their parents, or a spouse doing it for their partner. And we know that those that see themselves as caregivers, their outcomes are way better because then they ask for help. So help people, tell them, did you realize? And you will be surprised how many people are stunned by what you tell them. The other thing is, if you work in healthcare, include them as part of the team. And we're going to talk a little bit later. the implications of including families as part of the team. But this is what families want. If you ask them what they want to be part of the team and the decision-making. And then do something to alleviate their suffering. Whether it's counseling, whether it's resources, whatever it would be appropriate for that person. And there's the kinds of supports for older adults for the families of older adults are either psychotherapeutic interventions, education, respite services, and hands-on. And in Ontario, we know this is a big problem because there's no hands-on to be found. And those are to be found are really expensive. Respite services are dwindling. So it's sometimes really hard being a social worker, social service workers, and you have nowhere to refer people to. What people find super helpful is having a point of contact. So just if they know who to call, and in Ontario, even if you don't know anything else, you can refer them to the Ontario Caregiver Organization. I don't remember their number, but even if you call 211 or you tell the families to call 211, they'll send them to the OCO, the Ontario Caregiver Organization. Great resource, and they have trained counselors. I don't really know what their credentials are to support family caregivers and lead them to the right resources. But the best practice is multimodal. So we don't do one thing or the other, and this is true for all the populations we work with, but in particular with families of older adults. One thing's not going to fix it. And not only one thing's not going to fix it, but the needs change throughout the trajectory. So in the early diagnostic stages or when people start becoming caregivers, they need emotional support mostly. But as things become harder, they may need hands-on support, financial support. So what does this all mean? I just went through some clinical things related to older adults and working with their families. But this leaves us with a whole host of other issues to consider when we support families that we really need to be thoughtful about. And this is where I wish I had you all here so you could be asking questions. So as you have questions, please put them in the chat so that we can then discuss them during the Q&A. So I'm going to talk about confidentiality, privacy, charting, SDMs, powers of attorney, consent and capacity, advocacy and support, and cultural issues, which anyone that knows anything about this topic could do a whole day presentation on just one of these things. And these are huge topics, so I'm just going to go over it with broad strokes. Just for those of you that don't work in this area, just to make you aware that these things are a thing, so that you can learn more about it. First of all, in social work, we have this dilemma. Who's our client? So if you work in a hospital setting, for example, is your client the patient? Or is your client the family? Because the way our healthcare system is set up it's the patient's chart, and the patient is the patient. And yet, as in our professions, we work with the system. We work with the families as well. We include them. And so are they our clients as well? And a lot of it depends on the organization you work for. But I think it's up to you to challenge sometimes your organizations and the belief system. So in the long-term care facility attached to where I work, I was talking to somebody and they said the social workers shouldn't be helping the families. They're here for the residents. The last time I looked in long-term care, the majority of residents live with dementia And the social workers are not chatting with the residents. A lot of the work happens with the family. So challenge yourself to think, who's my client? Who are you supporting? And it doesn't have to be either or. Sometimes it's both. But think of the implications. Can you be a social worker to an older adult and also to their family? Especially when they're difficult and conflictual relationships. The other piece is around HIPAA compliance and disclosure of personal information. With older adults, we assume capacity always. However, some people, we have an ageist society we live in. Just because somebody's older and looks frail and maybe a little forgetful, a lot of people assume incapacity and they go straight to the power of attorney. And that's not quite how it should work. So sharing of information is really important. You have a lot of families. So I'm going to give the example of a long-term care facility where the daughter calls and says, I want to be informed of how my dad's doing. And the team is caught because, say, the wife says, don't give information to the daughter. And I'll go into it in a little bit more detail later. But I'm just raising these issues for you to think about who gives information, who owns the information, who discloses personal information. And families, just because they're families, it does not mean that they have access to their health records of people. People need authorization for it. And so in our professions, we need to be very mindful of what we share with whom, especially written records and verbal. So I shouldn't actually say especially written records. But don't go photocopying your chart. That's all I'm saying. Be careful what you say to whom. And sometimes it feels that it goes against common sense. But we do live in a society where there's rules and regulations, and that's what is. And we really need to learn to balance the need to provide effective care, but respect the older adults' rights to privacy as well. And again, when I talk about charting, whose chart is it? So social workers, social service workers, meet with a family. You say you work in a residential, in like a retirement home. And so the chart is really in the health unit is about the resident that lives there. But you're talking as a social worker with the daughter, and the daughter discloses some very important personal information. We don't open up charts for family members of people that live in a facility. We chart on the resident, patient, who's ever chart. Think of, is that okay to do? Just think about it in terms of confidentiality. Because the patient, the resident, has the ability to then look at the chart and find out information that the daughter may not want the person to know, and vice versa. So this is something, whenever I get to speak, it's just like, somebody please listen. We should have linked charting systems where you have a resident, patient, older adults chart, you have the family's chart, they're separate charts, but we should be able to know when I look into this patient's chart that there is a chart for the daughter, that as a social worker, I met with the daughter and there's information there. But then it keeps it private and confidential. I don't know if that's going to happen, but it's possible to do because I know I've tried it at the system. It's just people have to want to change the system. There has to be a case that gets brought up, that something goes wrong, and the system will change. But right now it costs money to do the linked chart system. It's creating more charts. So there isn't really an appetite to do this. However, this happens more in children's aid or working with children, sometimes there's 2 charts there. But for older adults, we don't seem to want to do it. How am I doing? Okay. So SDMs is substitute decision makers and powers of attorney. As social workers, we need to really understand what these roles entail for people, because a lot of the times in your teams, you are the person that explains all this to families and to your team sometimes. Powers of attorney are different than substitute decision makers, and I'll explain in a minute. And families may need support in navigating these new responsibilities. So an older adult has a stroke before they were fully independent. Now they lose capacity. And somebody instantly, like say a daughter, gets put into the role of being either a substitute decision maker, power of attorney, and I'll explain to you the differences. So substitute decision maker, you don't need paperwork, legal. The government has set out a list of people in the event that you become incapable who can act on your behalf, and generally is your spouse first, for older adults. I mean, it's different for children, but first your spouse, then your children, then your siblings. Generally, it's not your parents, because your parents are generally not alive. And you follow that, and you can find that on the Public Guardian and Trustee website, a list of who takes over. And that's if there's no legal documentation. For those people, which are actually a minority, who get powers of attorney, there's 2 types of power of attorney. One is for personal care. One is called power of attorney for continuing care, which is for finances and property. There's 2 separate types of powers of attorney. This creates sometimes problems, because you'll have older adults that say, my daughter's my power of attorney for personal care, my son is for finances and property. But guess what? If the daughter says, I want to keep mom at home with care, and the son who holds the finances says, no way, that's too expensive, even though there's money, that's money coming to me, we're not going to spend it on mom. The daughter who has power of attorney for personal care is kind of stuck, because you can make all the decisions you want for somebody, but if you don't have the money to do so. And so the role of social workers, social service workers becomes mediating sometimes these relationships, trying to negotiate, trying to see if something could be worked out. You know, I always say, it's like you can have in your office these people that look like they're managing adults, and they start behaving like 5-year-olds in your office. But mommy said this and mommy said that. And, you know, it's kind of, she loved me more because she gave me power of attorney. And you don't have power of attorney. It's my decision. It's important whenever you're able to try to mediate and help families see that really what we are working here is what's in the best interest and wishes of the older adult person, your parent, whoever that may be. And help them focus on who's the client here, who are we working for here. It's to best support your mom. What would be that? But that's a lot of the meat and potatoes of what we do in this business. So, and when things don't work out and we try our best, sometimes we go to the public guardian and trustee and calling them to run cases. I mean, they're very busy and they're not looking for business generally. And any of you that have called them regular knows this, but they're very good for chatting. Say, I have this kind of a case. What do you think? And I'm not going to say the college is there, but if you're really stuck knowing what do I do, you need to read up on what the role, what your scope of practice is and what you can do and what you cannot do. I just say this all the time. Social workers do not sign any powers of attorney, do not witness any of these. because there's repercussions for us as clinicians. So try to find a third party. And sometimes I've heard staff saying, I'm it for this person. They have nobody else. Let's go to the doctor or somebody else who's willing. When at all possible, try not to do any of this stuff. You can support people, you can teach people, but try not to sign any documentation. The other thing that is important to help families understand is around capacity. Because when we assess, powers of attorney, the legal documents, the other thing, they're only in effect when people are alive. When people die, the will takes over, and people get that mixed up. And the power of attorney it gets invoked at the point that somebody becomes incapable. It's not just because you have a power of attorney that you could go ahead and make decisions on your parents' behalf if they're capable. But assessing capacity is tricky because some capacity varies. And there's different types of capacity. So, for example, I may not be able to have capacity to manage my finances, but I can tell who of my 3 children that I want them to be my powers of attorney. And I recognize my children. And capacity to choose a power of attorney is pretty conservative. So I may be incapable to really pay all the bills, but I'm capable of something else. The other piece is depending on the illness you're living with, things change. So, for example, dementia with Lewy bodies, for example, one of the things about it is that they fluctuate. So you have people that are really bad at some points, really confused, and then they have moments of lucidity where they're really clear. And that's with dementia with Lewy bodies, that's a component of that illness. So what do you say? Is the person capable because they have lucid moments? But if you assess them during their bad times, they're not capable. So I want you to have that understanding that capacity is not something that is set in stone. It varies for people. And in Ontario, there's capacity assessors. The thing about it is you have to pay to have somebody assessed. And the client, the person being assessed has to pay. And it's about $1,000. It's not cheap. So really, if you're capable, who's going to agree to pay all this money to be assessed, to be told you're incapable? So it's a difficult situation. Admissions to long-term care or home and community care. Workers do an assessment to see if people, prior to applying to long-term care, and it's a role, most of them, but different people do, different organizations handle this differently. But again, your ability to choose where to live is a different type of capacity than your ability to manage your finances. And so in this field, we live in the grays a lot. It's not like this is the rule for this and this is the rule for that. We're used to this. So for us, it's when I started my undergrad, the best thing I learned was one of my profs said, if you learn nothing else, learn that the answer always is, it depends. And for us in social work and social service workers, we live in the it depends. And we are the ones that bring, here's some issues and here's some other issues. And it depends. So rather than just like fighting it, embrace it, because it's what makes us unique in many ways, that we can live in this area and not get frustrated, unlike some of our colleagues in other professions. How am I doing? Okay. what we could do also is provide families with ongoing support and counseling. People, it's overwhelming. Any of you that have experienced this, it's not an easy task. And although there's positives and there's a lot of research on positive outcomes for family caregivers, it's not something anybody wishes for themselves. And the positives come generally later on as we make meaning of our situations, where we can find. I had a client, I remember, who said to me, "I'm so thankful that my wife developed dementia. Because of it, I became really involved with my church because I needed help. And now I couldn't live without my community. It's something I never had before." I don't think he meant, thank God my wife had Alzheimer's. But positive things happen as we live through different experiences. So I would never ask a client, so what are some of the positives of being a caregiver, of looking after your mother? Because that's, again, we're making assumptions for people. But for some people, there are positives, especially later on. Help people manage stress. We know education is really important for people at the right time. So if somebody's newly diagnosed, say, with Alzheimer's, they don't want to know what happens down the road, that, they're going to fall and break a hip, that they're going to have swallowing problems, and they're going to choke and develop aspiration pneumonia, and that's how they're going to die. Give the appropriate information at the right time. This really helps families. And really connect caregivers to the relevant resources. And as I say, I want to go back to this connecting caregivers to relevant resources. This is where the skill set of our professions comes in. This is why we don't have a secretary handing out pamphlets and giving resources, because we're skilled at learning who needs what kind of resource when. And it's part of our clinical practice. And the other piece is about being aware of culture. So just like I told you about my colleague from India, I teach at U of T. I'm teaching right now a course, Aging and Health, graduate school. And somebody was saying, he's Chinese, and he was saying in his culture, you do not tell the elder what their illness is. You don't want to talk about death because it's bad luck to talk about death. And it could potentially, he was saying in their belief system, promote death. In our Western society, we want to be straight with people. We tell people the truth. We don't care what your culture says. It's my duty to tell you what you're dealing with. It's up to the person. But as social workers, we need to help navigate these discussions because it's not that simple. We know that. So being aware of language barriers. A lot of the times we are the ones that, very important decisions are happening and information, and the person doesn't really understand. Or we have the grandson. So this student I had, if he were doing the translation and he feels, I don't want my grandmother to know, we don't know what he's translating or not translating. So whenever possible, use professional translators. It will be better. A lot. Sometimes it's not possible, but try. And it's important for us to understand these differences. And again, not to judge, not to say, well, that's not the way it's done here. But to try to navigate this with our teams, with the families, try to help families explain why the doctor may be pushing for the mother to know what's wrong with her.
Yeah.
And so as social workers and social service workers, we have a responsibility really to continue our training in terms of what are our ethical standards, what are legal requirements, what is cultural competence, and we need to stay informed and be prepared to handle very complex cases. Because as people age, the cases don't get easier. They become more and more complex. Don't try to be an island unto yourself. If you work with teams, if you have colleagues, ask for support. There's nothing wrong, and in fact, that's the beauty of working in teams. These cases can be really difficult, and especially if you work in a team with different disciplines, there's power in hearing the different perspectives. And we don't always have it right. As I said, give people appropriate resources. And I want to emphasize this area of self-care and supervision for social workers. When I started as a social worker in the 80s, it's a long time ago, I used to have a supervisor who I used to bring my clinical cases to on a regular basis and discuss. That's not happening now in most places. And it becomes very difficult sometimes because the cases are very traumatic some of the times. We hear stories that are really difficult to take in and we don't know what to do. And there's the emotional piece, there's the legal piece, there's so many areas that we need to deal with. Look after yourselves, understand there's secondary trauma for us in this work, and try to get supervision or speak to we all report to somebody. That's just the way it works. Speak to somebody in your team. Have colleagues and debrief. So before I finish up, I just want to leave you with some resources. Baycrest, the Baycrest website, and that's baycrest.org, has really good information around caregiving, end of life, mental health, and this is all related to older adults. And if you go to the health and wellness portal, you can find, maybe you can't find, but try to find the resources. We also have a lot of resources around caregiving for older adults on the website. We have a series of well over 40 webinars that are recorded and stored in all different areas related to family caregivers of older adults. Every topic you could imagine is there. There's great stuff. Look through the titles, and we have great experts talking about powers of attorney, SDM, mindfulness for caregivers, real estate, abuse, elder abuse. I didn't even talk about that because that's a whole separate conversation. But it's generally adult children who are the number one culprits of financial abuse of parents, emotional abuse also, and there's scams. There's a really great webinar on that as well. And then there's 3 e-learning modules. They're really good. They're quick and really helpful to help people that don't work with caregivers understand what caregivers need. Also for caregivers themselves to know how to ask for help. And also for those of us that work with other people that may be in caregiving roles to support them. And the other piece, there's a lot of us in this business are being paid caregivers, but we're also personally caregivers, and that takes its toll. So I'm going to open it up for questions.
Fantastic, Adriana. Thank you. As Adriana said, we now have some time for questions, and attendees can enter their questions through the chat feature on the right-hand side of their screen. And a reminder that the chat feature is only available for those accessing the session on a computer or laptop and not from a phone or tablet. And we've had a very active chat so far, which is really interesting. People talking about the differences between SDMs or substitute decision makers and powers of attorney. People talking about the difference for assessing capacity for long-term care, finance, and even treatment as well. Interesting observations as well about people needing to really understand about consent and capacity, the Healthcare Consent Act, Substitute Decision Makers Act, really interesting conversations. Wondering, a question that came through is, how do we manage the needs of a caregiver when they conflict with the older adult that they provide care for? The older adult, as an example, the older adult doesn't want to go into a care home, but the caregiver states that they do want them in a care home.
Well, so it depends. It depends who's your client. It's older adults. Most people, 99% of people, if you ask them, do you want to go to a long-term care facility, a nursing home, they'll say no. Really, why would you want to? Nobody wants to. And they may be capable to make the decision. The difficulty is that they can make the decision, but if they don't have the supports in the community, it's not going to happen, right? So I may decide I'm going to stay home. But if I have mobility issues, if I can't get up the stairs, if I can't cook or get food, there's services that could come in, but somebody's got to organize that for me. And so these are discussions that we need to help families navigate, because it's not so simple. It's generally somebody else making the decision for somebody to go to long-term care. And then you have what's difficult is you have adult children who promise their parents that they'll never put them in a long-term care facility. And now they feel this horrible emotional grief around, how am I going to do this? But I can't manage my parent at home. So it's having these difficult conversations. And I'm not going to say you do this, this, and this, but you need to first assess capacity of the older adult. Because if the older adult is capable, sometimes you need to help the family understand that they need to fail, or there needs to be a crisis, sometimes more than once, before you could do anything. Because even though you know that it's not going to work, the person has the right to try it. And it's important to note that this is true not just for families, but for healthcare teams as well. A lot of healthcare teams are very paternalistic and will decide, well, they're not fit to go home, they should go to long-term care, even though the person's capable and wants to go home. Did I miss a component of that question?
No, I think you covered that. Thank you.
Okay.
And I love going back to, it depends. A lot of people in the chat agree with that as well. Other question, if someone has a power of attorney, but the power of attorney lives outside of the country and the doctors can't get a hold of them, but there is a family member who lives locally, would the family member who lives locally then be responsible for making the decisions?
No. So it's only up to the power of attorney to make, so if it's power of attorney for personal care, because if it's for finances, that's separate. So if you cannot get a hold of the power of attorney, it's not for the person without power of attorney to make those decisions. Sometimes those cases have to go to public guardian trustee, consent and capacity board. If it's an emergency, the healthcare team may just make decisions if there's no time, like it's life or death. But it's legally, if the person's incapable. Again, we get mixed up with, sometimes people are capable, but there is a power of attorney. And so the family said, well, I'm the power of attorney. Yes, but the person you look after is not incapable. So it doesn't really matter who the power of attorney is. And so we need to remind people of that and remind ourselves that being a power of attorney only takes effect at the time of incapacity.
That was some of the comments happening in the chat as well about understanding when the power of attorney takes effect.
That's right.
So really important reminder for people.
Yeah.
This is a longer question. So do you have any recommendations for how caregivers can best advocate for their person while in hospital or long-term care? How do we help folks navigate the tension between what they perceive their person needs, or their person may be complaining about care, and how the daily care is provided and what the care team recommends? This can become confrontational between the caregivers and the staff, and the caregiver feels caught between their person and the system.
And that is a very common experience of caregivers, where caregivers talk about when they get into the hospital, the long-term care facility, putting their combat boots on, because you become an advocate of your person. And really the best way to navigate that is, I always say to people, you get bees with honey, not vinegar. Families, unfortunately, that start screaming and yelling and blaming, when people see them come, they run the other way. Nobody wants to be yelled at. So it's important to help families see that the way we communicate with staff will have an impact into the care, or for us, them wanting to work with us and help us. So every clinician understands, I shouldn't say every clinician, but most clinicians understand that families are in pain. And they're really advocating. And if you were in their shoes, you'd be doing the same thing. So it's helping, teaching families how to better communicate and helping them understand they're in an institution and it's not one-on-one care, and you have to let go of some things and you pick your battles. You need to help people understand which are the important battles and which ones are some that you're willing to let go. But being angry and just screaming every time you go is going to alienate them from the team. So teach them how to put themselves in the shoes of healthcare providers. Most people that go into healthcare don't want to do a bad job. Maybe they need to speak to the manager of the unit, not to the nurse or whoever that's providing the care. And help them understand that sometimes when we're in grief as families, anger is a way that we express grief and depression. Some people are just become really well defended and just screaming at the world instead of acknowledging what they're going through. And sometimes it's helping people sit down and see how painful what they're going through is and kind of de-escalating it in that manner. And we have the skills to do that. This is especially what we do when we do well.
There's been a little bit of confusion in the chat as well between the differences between power of attorneys and the substitute decision maker hierarchy. So if you could maybe outline that a little
Sure.
bit.
So powers of attorney are legal documents that are done at the point, and all of us should have them if we have people that we trust at the point. So at the point that I become incapable, I have who I want to make decisions for me and who I want to manage my finances. I went to a lawyer. You can also download them from the Ministry of the Attorney General. But if they're conflictual relationships, I don't ever suggest that you recommend this to families. But the kits are there put out by the government. So these are legal documents, and you can make your power of attorney the grocery store clerk that knows you well. There's no rules or regulations about who your power of attorney is. It's important as social workers that we tell people it's a very powerful document and be thoughtful about it, because we've seen plenty of times the power of attorney, you could be in hospital with a stroke, temporary incapable, can go to your bank, sell your house, take all your money and run, and there's nothing you could do because you gave them that power. Your power of attorney could put you in a nursing home, even though you have enough money to be kept at home with 24-hour care. So in the event that somebody, I used to tell people, well, make sure that you have a power of attorney. Now, I don't think that anymore. Unless you have somebody you really trust, you're almost better off not having a power of attorney. Because if you do it with somebody that you don't trust, that could take advantage of you, it's ripe. The situation's ripe for abuse. Anyway, so that's a power of attorney. And there's 2 for personal care and for property and finances. Substitute decision maker is at the point that you do not have those legal documents, which is the majority of people don't have powers of attorney in place. And there's a list of who makes decisions on your behalf based on relationships to you. So your spouse is number 1. If you're an older adult, then your adult children. And you can, the list goes on. It's on the Ministry of the Attorney General. You can find the list of substitute decision makers. And this is for the majority of people in Ontario that do not have powers of attorney in place. But power of attorney trumps substitute decision maker. So I'm married, I'm older, and I made my daughter the power of attorney. If that paper wasn't there, it would be my partner, my spouse, who would be the substitute decision maker. But because I gave a power of attorney to my daughter, she trumps then my husband as a substitute decision maker. You see, so powers of attorney will trump the regular, levels of, the hierarchy, thank you, of substitute decision makers. Is that kind of clearer? Yeah.
Thank you. Absolutely. Last question I'm going to have too is a lot of questions about if you have any translating recommendations for having a proper translator for people who might need one.
So the government of Ontario, for hospitals, there's a phone number and I don't know it. And I don't know if you want to Google it and put it in the chat, but there is for translation services. The problem is there's a cost associated with it. And a lot of hospitals and places don't have it in their budget. They're not free. So this is the problem and I'm not talking just hospitals, any organization, find out if your organization pays or is willing to pay for translation services. And if not, you try to find another staff member that could do it. But try to have a translator. But again, it's not always possible. Then, do I move to the side? Yeah.
You can stay. Oh, okay. That's okay. You can stay. Yeah, okay. That's all right. So Adriana, thank you so much for your presentation. It was really enlightening. There was a really engaging and interesting chat as well. It really was surprising to me because, as a side note, Adriana and I used to work together. And since I am no longer at that organization, I hadn't heard that 65% of our older adult progress is really environmental, right? And then to also hear about, caregivers of individuals who have dementia, that they have a 600% chance, the greater chance of getting dementia themselves. And it just really speaks to the social determinants of health and to privilege. And, that was really shocking to me and really stood out from your presentation today. So I really appreciate that. As a token of our appreciation today, we've made a donation to the Indigenous Women's Fund of Canada. We have a little name for you here.
Thank you.
And just really thank you again for participating in Ahmed this year.